Hi, everyone. Thanks for joining us. We appreciate having all of you. As we're waiting, love it if you could share in the chat where you are from and how would you describe harm reduction? So we'll wait maybe just another minute. I think we have people still joining. So thanks for joining today. Welcome if you've just arrived. If you could share in the chat where you are from and how you would describe harm reduction. So Mary Jo, we've evened out at about 30. Would you like me to get started?
Yeah, that would be great.
Sounds good. Well, welcome everyone. Thanks for joining us today. My name is Laura. I'm here from the College of Pharmacy in Duluth, University of Minnesota. I'm happy to do this presentation. I've been working in the area of harm reduction, for like 8 years now, actually, maybe more than that. So I really want to thank the community members and people in recovery that have taught me everything that I know. I just want to acknowledge that. So if you haven't already, we'd love it if you could share in the chat where you're from and how you would describe harm reduction. And if you don't have a way to describe it, that's fine too. And we're also interested in why you're participating in today's webinar. Is this for personal use, for professional use, or for personal and professional use? So I'll let you put those in the chat. And Mary Jo, I can't see the chat, but can you let me know what folks are saying?
Yes. So let's see. So some things around harm reduction is doing less of harmful things rather than stopping completely. Lessening the risk to individual safety and health. To me, harm reduction equals compassion. Harm reduction is meeting the client where they are at and not non-judgmentally working alongside with them to increase safer use of substances. And means making things not quite as bad as they could have been. See, helping people to stay safe and healthy while using substances and treating those with SUDs in ethical and programmatic ways. And one more, recognizing that people still need safety and care and housing, and addiction should not halt people's ability to get care and safety in housing. So lots of good things in the chat. Thank you so much, everyone.
That's great. That's a really great place to start. So thank you for that. So we're going to go ahead and get started with our presentation. Really briefly, some objectives. We're going to talk about past and current trends in substance use and how they inform community-based harm reduction. We're going to talk about the health and social benefits of harm reduction programming. We're going to look at some common myths about harm reduction and describing the benefits of and evidence behind harm reduction approaches, including naloxone use, syringe access, and fentanyl test strips. And then strategies to reduce stigma and engage patients in care related to substance use disorders. So I'm going to ask this question. If you could take a look, and this is usually where I kind of like to frame this conversation, and probably this is a group that already sees some value in harm reduction by making time in your own busy schedules for this, but just kind of take a look and think about what do these things all have in common. And if anyone is able to share in the chat, Mary Jo can tell me, or if anyone wants to speak up too.
Let's see. Yeah, you may unmute if you like to, but some of the things are these things save lives, protection. Let's see, anything else? There's some other things around just harm reduction in general, but
Yep. Okay. Well, good. So these are all, we know that these tools save lives, right? Like these are pretty well-established tools to save people's lives. So we have a seatbelt because we know that even though cars and motor vehicle accidents are they can be pretty dangerous, right? We hear of people losing their lives in car accidents. We still choose to drive, right? We choose to drive despite those risks. I have a young driver, actually two younger drivers. It's terrifying if you have a child who's just got their license or their permit, but we still let them drive, but we make sure they are wearing their seatbelt, right? That is really, really important. We have a helmet here because we know that bike accidents can be lethal, right? Bikes and cars, again, don't mix, or people riding bikes can be really, really seriously harmed if they hit their head. And so we wear a helmet and we don't think about it, right? Like it's just an accepted tool because we don't know when we're going to get into a bike accident. We don't know when we're going to get a car accident. So we use these two things because we have the tools available and they are accepted and they save lives. And we just do this, right? We don't see cars that don't have seat belts. Hopefully we don't see too many people riding bikes without helmets. We also have a fire extinguisher here. So again, like we never know when we're going to have a fire in our house, right? We don't just buy a fire extinguisher because we think this is going to be the month that my house is going to burn down. We're going to have a kitchen fire this month. No, we don't think like that. We just recognize, you know what? If I were to have a fire, like I definitely need to have a fire extinguisher. And usually we have more than one. We might have one in the kitchen, one in the garage. People have these things available just in case, right? Because you just never know when you're going to need it, and it's accepted. And then we have a vaccine too. So here's an example in all of our vaccines, right? Like we have a lot of vaccines that we know are saving people's lives, and they're generally pretty well accepted. Some of them are maybe a little more controversial. So the Gardasil vaccine may be a little more, that's for HPV, but if someone gets cervical cancer, that can be deadly, right? And so we have vaccines to mitigate risks and to save people's lives. We know lots of people's lives get saved because they've had the influenza vaccine or the COVID vaccine. And so these are all things where we have used science and really looked at data and realized we have a tool here that saves people's lives. Why don't we use them? So the thing about it is though, like, is there a stigma in going and purchasing a fire extinguisher? Are people afraid to do that because of what other people might think? Are they afraid to get a helmet? Are they afraid to put their seatbelt on? No. So the reason that these harm reduction tools are well accepted and other harm reduction tools that we're going to talk about are not as well accepted is because of this issue of stigma, which is the big issue that's going to pop up multiple times. Those of you that work in this area already know that. Probably all of us know that, right? If we're attending this presentation, we realize this is an important topic and we want to be educated on it. So stigma is the big thing that we're up against when we talk about harm reduction, and really is such a huge barrier to people getting help for their substance use disorder. So these are things, again, these are also tools that are based on evidence. We know they save lives. The data tells us that, and yet for some reason, these are not as accepted, right? So we have a medication, Narcan, or naloxone, which is one of the best drugs. So I'm a pharmacist by training. There's a lot of drugs out there that have a lot of side effects, systemic side effects, where if we gave somebody this drug and they didn't need it, like we could cause them serious harm. Even medications that we buy over the counter, such as ibuprofen and Tylenol, can have serious effects on people if they take too much of them. But here we have a drug that only works on one specific receptor and only does one little thing, and yet there's so much stigma against it. It's a pretty safe drug. Nasal dryness is the side effect for Narcan nasal spray. And yet there's stigma against Narcan and naloxone. And then we have fentanyl test strips. So this is another evidence-based strategy where people can test their drug supply to see if there's fentanyl in it. And this is, of course, very important because fentanyl's in a lot of our drug supply, most of it right now. So it's really important for people to know if there is fentanyl so that they can adjust how much substance they're going to use or maybe not use it at all. And yet there's stigma against this tool. And then we have needle exchange or syringe access, which is another evidence-based strategy. Lots of data shows that syringe access programs save people's lives. They reduce the spread of disease. They basically save a lot of money too, because treating hepatitis and HIV is very expensive. not to mention like the impact on people's lives. And yet, why is it so controversial? It is because of stigma. So what is harm reduction? Very simply, it is doing things that make it safer for people to participate in activities that may lead to harm, but are really unrealistic to ban or eliminate. So can we realistically eliminating contacting other people? No, we're probably going to be like talking to people and out in social gatherings. So we have vaccines that can help protect us in that situation. We can't really realistically stay out of the sun completely for a lot of us, and so we have sunscreen to help reduce that risk. We're going to drive despite the risks, right, to get to our jobs, and it's a part of our lifestyle. So we have seatbelts, and then we also have sex, so we have condoms. And this one I think is one where we can see. Here's an example on the right hand side of some messaging about condoms. So you can see on the top it says, I didn't use one because I didn't have one with me. And then it says, get real. If you don't have a parachute, don't jump, genius. And then there's a picture of a condom, Trojan, and says, help reduce the risks. So again, there's some messaging like, come on, just kind of aligning that people are going to do what they're going to do, but you need to do it safely. So that is kind of the basis of harm reduction. So here's a figure as to why this is important here. And you can see this is national drug involved. Oop, I got to move my national drug involved overdose deaths. And you can see the numbers through 2020. We always have a little bit of a delay in getting data. So I think we maybe just recently got 2021 or will be soon. They're always about a year behind. But you can see those numbers continue to rise. And the preliminary numbers for 2021 showed that continued to rise at the same steep incline. So what I'm looking at here is on the left is 1999, on the right is 2020, and we can see the total number of drug overdose deaths has continued to rise every year. The numbers for males are consistently higher than females, but they're kind of parallel graphs. Both trending upward. And then you can see a sharp increase starting in 2019, going up through 2020. And if we looked at 2021, we would see that as well. So, and so I'm going to back up a little bit. We're going to talk real briefly. So why did we see this sharp increase in the last couple years? So part of it is definitely that there's more fentanyl in our drug supply than there ever used to be. So they found fentanyl in pretty much all drugs of abuse, and people are getting fentanyl, using fentanyl, and not even knowing they're getting it. So people that never intended to use an opioid. So opioids include heroin, for example. Heroin and fentanyl are both opioids, as are like prescription opioids like hydrocodone and hydromorphone and morphine and oxycodone. So those are all opioids. So people are finding fentanyl in their drug supply, even if they're like a methamphetamine user or a cocaine user where they never intended on getting an opioid. They've even found it in some marijuana. So it's very, very dangerous, very, very potent, and people don't even know they're getting it. And so that's been part of the reason we've seen this steep increase. The other reason is because of COVID. So we've seen people who have been stable in their recovery all of a sudden now with COVID and all the social supports that help keep them in recovery are gone. So we have people struggling with using drugs who maybe had been in recovery. We have people that maybe dabbled in substance use that were starting to use it more because of all the stresses with COVID. And then we had people that were using drugs for the first time in COVID, again, dealing with things like isolation and job loss and depression and death of loved ones. So it was really a horrible storm. So over 70% of the nearly 71,000 deaths in 2019 involved an opioid, and that number continues to increase. So you can see 3 waves in the rise in opioid overdose deaths. The first one, and some people, I think the media still think we're in one. I get calls from media sometimes, and they still think that it's about the prescriptions, and it's really not at this point. But the first wave was a rise in overdose prescriptions, overdose deaths related to prescriptions. And that started in 1999. And so there was just not a lot of regulation in opioid prescribing, not a lot of perceived harm on the part of prescribers and pharmacists. This one was largely due to healthcare professionals, I would say, not being as vigilant and looking at data to really see if this prescribing was safe. Once we realized, whoa, we're overprescribing and people are becoming dependent on opioids, then there was this phenomena of people being cut off from their opioids, where all of a sudden they had maybe been stable on an opioid dose and their prescriber realized they might be dependent. So I'm just going to cut them off, or I'll wean them off really quickly and they'll be fine. Well, we realized then, no, they're not fine. They are dependent on this drug. And so because they're dependent, if they can't get that opioid from the pharmacy, they're going to try to purchase it off the street. If they can't purchase it off the street, they're going to probably turn to a different sort of opioid. And heroin is an opioid that's very cheap and easy to obtain. And so that's where we saw this rise in heroin use and then heroin overdose, which started in around 2010. Then we saw more synthetics such as fentanyl in our drug supply. So that's when we started to see this third wave and that was because of the rise in synthetic opioids. And then I'm going to say, honestly, like right around COVID, we're probably going to call this a wave 4 that really had to do with not only this rise in synthetics, but then the social impact of the COVID-19 pandemic. So it's a long story. Our America's relationship with drug use today started with Nixon's war on drugs in 1971. And it was an aggressive and expensive project that was aimed at curbing drug use in the United States, but really not a lot has changed since then. And the approach just wasn't very effective. So you can see the teens, which are the most common age group to use drugs, showed little net reduction in drug use since 1975, according to this Monitoring the Future survey here. So this is a graph of the percent of the high school seniors reporting illicit drug use in the past month. We can see, sorry, somebody's pounding on the wall next to me. There's a rise in between 75 and 80, then it goes down in 92, and then it's just been about stable since then. We can also see, per the Office of National Drug Control Policy, the prices of drugs have been falling dramatically. So you can see I have a graph here of the median bulk price of heroin per gram has gone down a lot. So heroin's been becoming more and more affordable, still accessible. And so between 81 and 2007, the median bulk price of heroin fell 93%. In that same time period, the price of cocaine fell 87% and the price of crack fell by 54%. So this effect then, where we're cracking down on drug production in one area, is just shifting it to another area, and it's called the balloon effect. It's often cited as one of the reasons that that the war on drugs didn't really work. It's just a shift in drug availability. One thing we do like to point out when we're doing presentations like this, because people think about treatment and relapse and they feel like, oh, well, I can't give somebody, I don't know, we have problems with prescribing of medications of opioid use disorder because people think, well, this is just substituting one drug for another. We have prescribers that don't want to give out naloxone because they feel like naloxone is just enabling, but this is actually not true here. So you can see if we look at the rates, relapse rates for substance use disorders, they're really on par with other chronic diseases such as hypertension and asthma. So about 40 to 60%. And so, but when somebody with asthma has a relapse, we don't stigmatize them, right? So and we don't deny them their rescue inhaler like we do with people who have a substance use disorder. So I like to compare asthma and substance use disorders because I see a lot of parallels. So, sorry, my lights go out if I don't move enough. So people with a substance use disorder, we have medications to keep them in relapse, right? So, I'm sorry, not in relapse, but we have medications to control their symptoms. So those are medications for opioid use disorder, for example. We also have rescue medications. So if they were to have a relapse, we can save their life. So that would be like naloxone. So we have these controller medications and we have rescue medications for substance use disorder. We also have the same thing with asthma. So I have 2 children with asthma. They both have their regular inhalers. So they have their controller meds and they're on other meds too to help keep their symptoms controlled. But if they were to have an asthma flare-up, I also have a rescue inhaler and I have a nebulizer and I have tools to help them And I'm really thankful that if they were to end up having a relapse and needing their rescue inhaler, that people aren't stigmatizing against them and discriminating against them for needing their rescue inhaler. And yet, we have this phenomenon with substance use disorders where there's so much stigma and people are afraid to get their medications for opioid use disorder because they get stigma asking for them. We have healthcare providers that won't prescribe them because they're afraid of what kind of clientele they're going to get. We have pharmacies that make people feel bad in picking them up. There's just so much stigma. And then if they were to use naloxone, they are stigmatized in picking up naloxone when they go to the pharmacy. It's just really sad and heartbreaking. Again, the underlying issue is stigma. So it's just really important to be aware of that. We have harm reduction tools. They are very well based in evidence. However, this issue of stigma keeps coming up and keeping people from getting the care that they need. So really, for healthcare providers, especially at these rates, addressing substance use disorder relapse should be an expected part of our work, just like any other healthcare condition. So again, it ties into stigma and shame, how we really need to be honest about rates of reoccurrence and help others feel safe in asking for help. So again, because of this, we know that eliminating drug use altogether seems more and more like an unrealistic goal. So really, harm reduction tools offer a way to reduce the harm stemming from drug use. So we have some myths to look at. So we know that harm reduction is not embraced by everybody. And so we have some myths to look at here. So one myth, harm reduction promotes harm to the community. And so this is, I think, people that see we're giving someone naloxone, they say, oh, well, you're just enabling them. We're handing out new syringes, and they say, oh, well, those are just going to end up in the community. But really, the fact is that harm reduction programs are shown to be a cost-effective way to slow rates of HIV transmission in a community. So those are the new syringes, especially. Even better, we know that harm reduction programs are shown to facilitate connection to social program and support people who use drugs and making them more likely to enter treatment. So somebody just engaging with harm reduction services is more likely to seek help. And in some places where they've developed even more harm reduction services, such as supervised injection facilities, they find even better outcomes. There's also a myth that harm reduction only enables and increases drug use. And this is, again, false. There's no connection between harm reduction and increased drug use. Even better, since harm reduction groups typically offer used syringe disposal and hand out medical sharps containers, their presence is correlated with fewer discarded syringes in public spaces, and a lot less work for law enforcement to do too, because a lot of times they get called in. So we are finding if people actually look at the data, it's showing us that harm reduction is a very good investment in resources. I'm going to take a quick pause. I've done a lot of talking. What questions do you have at this point before I talk specifically about naloxone? And I cannot see the chat since I'm in sharing mode. So Mary Jo, please let me know if there is anything there.
I will. And please also, if you want to unmute, you can do that and ask your question as well. Okay, there's nothing in the chat right now. Oh, there is something in the chat. What prompted the dramatic drop in illicit drug prices?
I think it's just a shift of supply and demand. And I think I mean, there's drug producers all over. And I think if they realize there's a market, then they're going to make it more accessible. And so probably also advances in science. I mean, I hate to say it, but like advances in science within all levels of scientists. And maybe, you know, as people are finding ways to make drugs in the United States instead of having to import them too. If there's a demand, they're going to find a way to meet that supply.
Another question is very curious to know what harm reduction resources are available in rural Minnesota.
Okay, that's a very good one. So we actually, and Mary Jo can type this in the chat, we have a group called the Rural AIDS Action Network, which is one of my main partners for harm reduction, and they pretty much, rural is their focus. And so they do have a lot of ways to get harm reduction services to rural Minnesota. We also have Harm Reduction Sisters, which depending on the part of the state is another resource focused on rural. And then we have Steve Rumler Hope Network, which has rural hubs located throughout the state as well. So between the three of those organizations, depending on where you're at, and you can email me individually and I can figure out who's closest to you with you. I'll have my email at the end. Those are the resources that we have in Minnesota. Okay, so we're going to talk about naloxone real briefly. Naloxone is the generic name for Narcan. So this is a drug that reverses opioid overdose. It's a great drug. It's a high affinity mu receptor antagonist. So what that means is that it binds to the mu receptor in the brain, and it's great because it only binds there. Like I said before, there's lots of drugs that have systemic effects. They work all over the body. They can cause all sorts of side effects, but this one's pretty specific. So how it works is if somebody is to take an opioid, whether it be taken orally, injected, intranasally, it ends up in the bloodstream, binds to the mu receptor just like this. And when it binds, it turns off your body's desire to breathe. And so we have a drug called naloxone, which can be given injectable, comes in a vial, or intranasally, comes in a little plunger here. And basically it restores your body's desire to breathe. It binds to that same receptor, but doesn't send that same signal to the brain to stop breathing. And so whether you give it intranasally or injected, it ends up in the bloodstream, comes along, kicks the opioid off the receptor, binds in its place. When it binds, it basically makes your body start breathing again because that desire to stop breathing that the opioid sends, it's gone. So it takes the place. It doesn't do anything else in the body. So if you're wrong, maybe it's something that this person's having, like maybe it's something else that's making them not breathe normally, and so they're not breathing and they are non-responsive. Those are the two things we're looking for. You can't harm them. So it's safe even if there's no opioids present. So it comes in a couple different formulations. We have the Narcan nasal spray and the injectable generic, and we do have a full training on this. So if this is one of our most valuable harm reduction tools. We have a training for it through the Extension website, and another training next week focused specifically on this. So feel free to register for that hour-long training if this is something that you want to get trained in. So we do have harm reduction agencies across the state of Minnesota, the ones I mentioned. The Rural AIDS Action Network focuses most on rural. Harm Reduction Sisters also is mobile, and Steve Rumler Hope Network. And we also have a protocol in the state of Minnesota that allows pharmacists to prescribe. So you should be able to go into any large chain pharmacy for sure and be able to pick up naloxone from there. We also have a Good Samaritan law. So if somebody is with someone who's using drugs and seeks medical assistance for them, they cannot be charged or prosecuted for possession, sharing, or use of a controlled substance. The exception of this is if they have a felony on their record, which we learned from a question from one of these presentations. So some myths about naloxone is that it's a controlled substance. It's not. There's the myth that there's going to be aggressive behavior after administration. This is also a myth. It's not necessarily true. There can be some aggressive behavior if the person is on meth or cocaine at the time of taking naloxone. There's also the myth of harm related to administration, that it enables continued opioid misuse and of liability, and these are all incorrect. We also have syringe access programs, which are called needle exchanges or syringe exchanges, and they take in used syringes and dispose of them as medical waste. We're really trying to get away from terminology clean and dirty. We still catch ourselves saying that, but we could try to say, instead of clean syringes, new sterile syringes. They also distribute tools to prepare drugs, offer HIV and HCV testing, hand out naloxone and fentanyl test strips, and then offer connection to treatment recovery. And again, people that engage with harm reduction agencies like this are more likely to seek care for their substance use disorder. They also can offer medical screening and help with wounds.
Laura, do you know if Steve's law applies to tribal nations?
As far as I know, yes.
Okay, thank you.
Yeah, but with tribal nations are independent sovereign nations. So it would be best if you are working with one specific tribal nation to really clarify that, especially if you're working in the area of substance use, because every tribal nation handles things differently. but a lot of times they will use the county medical response, if that makes sense. So tribal nations are situated within different counties and different jurisdictions, and so it really depends on who responds, but it should be respected within tribal nations as well. It just depends on if there's a tribal law that supersedes Steve's law. So that's why it's important to know your community. So good question. Per the CDC, syringe access programs save lives by reducing the risk of overdose. We know this. They're associated with a 50% decline in HIV transmission. We know that users are 3 times more likely to stop injecting drugs if they're using a syringe access program. And again, the benefit for law enforcement: reduced risk of needle stick, no increase in crime, and lives saved. And of course, 86% fewer syringes in the community is really, really great when compared to a community without such syringe service. They also are more like areas that have syringe access are likely to have lower rates of HIV and hepatitis C. People who inject drugs and use syringe service providers are 5 times more likely to enter treatment than people who do not use them. And they reduce healthcare costs by preventing HIV and HCV as well as overdose. So there's just a lot of data. I could put like 5 slides on the benefits of these. So I definitely encourage you to look into that if you're not familiar with that data. Another tool we have are fentanyl test strips. This is something that we've seen more demand for. Although now with fentanyl in a lot of the drug supply, people are not surprised when they find fentanyl. So I fear that it's not changing behavior as much as it used to. There's also newer drugs that are not fentanyl, like xylazine, that these don't test for. So, but these are products that are designed for testing the drug supply for fentanyl. They can be repurposed, inexpensive and sensitive. But again, like when there's new synthetics on the market, we can't detect all of the analogs. So training is important. We usually provide some training on a card when we dispense fentanyl test strips to people in the community. So I'd encourage you to take a look at these. So more and more of the street drug supply does have fentanyl. So again, people maybe just assume that there's fentanyl in their drug supply, but it does help to reduce risk overall. So another new harm reduction tool that we have in the United States now, we have a couple of them, are supervised consumption sites. These are more well established in Canada and Europe, and we are a little slow to this in the United States. But these are sites for people who inject drugs to do so safely under the supervision of trained personnel. They've been found to reduce the volume of discarded syringes in the community. They increase connections between people who inject drugs and healthcare providers, and they save a lot of lives. They save money and HIV prevention alone. So there's 100 sites in 11 countries, but just a few in the United States. So there's one in New York and one in Rhode Island. We actually have a work group in Duluth that are looking at the initial steps needed for a supervised site in Duluth. But it's slow going, of course, because of stigma. People don't understand the data. And then lastly, another newer area in harm reduction is decriminalization. So this is not, there's some differences. Sometimes people think decriminalization is the same as legalization. That's not true. But what decriminalization basically minimizes social exclusion of people who use drugs and creates a climate in which they are less fearful of seeking and accessing treatment, using harm reduction, and receiving services. So Portugal, for example, is the one example that people kind of look to. They decriminalized illicit drugs in small amounts in 2001, which then led to a reduction in the number of recent and current drug users, a reduction in new HIV infections, and a reduction in drug-induced deaths. So how it's different, decriminalization is when you remove criminal penalties for use and possession. Legalization is when you remove criminal and civil penalties, like citations. So decriminalization does not mean that there's going to be no civil penalties. There is. It just removes the criminal ones. So again, decriminalization is when the police give tickets for possession and make arrests if the tickets aren't paid. Legalization is when they just regulate it. So New Jersey regulates and taxes marijuana like alcohol. So there's some differences there. And this is an area where I'll be honest, I'm not an expert, but when you're really doing your research in the area of harm reduction and what are the newer practices, this is one that gets brought up. So that is the end of our formal presentation, but we generally have some time and some good questions when we do these. So I'd love to open it up for questions and comments, and maybe there's experts that have joined us that want to share what they've learned as well. So feel free to unmute and ask your questions or share your perspective. No questions.
I don't see any questions in the chat. I also did add some resources that we have from our website, Laura, just around harm reduction, our naloxone, the video that you talked about, as well as our mini courses that we have, and some other educational videos, so that the folks want to check those out as well.
Thanks everyone for joining. You do have my contact information. I'll put it in the chat again. I just kind of wanted to see if there's faces. So if you have additional questions, maybe you didn't want them on the recording or you didn't want to ask them in this group, that's just fine. Send me an email and I'll help you find resources or answer the question as best I can. I just want to thank you again for joining. Mary Jo, was there anything else that you wanted to
yeah, so if you the slides, I know we have a few more slides, just and I'm going to grab the link too, but we have an evaluation that we would really love to if you would fill out. Let's see, I'm just going to grab it here. It's on the slide as well.
So can you see my slide? z.umn.edu/recovery 2022.
Thank you. And we will be sending this out too in an email as well. And we have another series of webinars that will be coming up soon, starting in January to April. So look for, we will share those as well in our follow-up email, along with the recording and the slides. The other thing I did put in the chat is that we do have one more webinar that it's around our health and recovery series, and that is on Monday, that Laura will also be doing around overdoses. And so you can sign up for that. I put that link in the chat. If you need it again, let me know. Otherwise, I think Laura and I will stay on for a few minutes if folks have questions, but again, thank you for joining us.
Thank you. Mary Jo, do you want to stop recording?
Yes.
Sometimes in my experience, sometimes people don't want to be recorded, but maybe they'll ask the question once it ends.
Yes.
I can